Thank you, Jess, and sorry for all those words that I made you say in that introduction. All right, today I'd like to talk about falsified medication use in the general population. So in overview, I want to really focus on this question of who may be at risk from using and being exposed to falsified medications. We're going to start first with some background. What do I mean by falsified medication? And what do respondents think we're asking about when we ask them about falsified medications? Talk a little bit about methods, where the data comes from, go into a little more detail into one of our data systems, and then spend a bit of time in these two questions. One, who are at risk, and what risks are individuals reporting that they're experiencing from falsified medications, and then conclude a little bit. Before we start, I'd like to acknowledge the whole team at RMPDS working on this entire meeting day, but in particular for this meeting, I want to thank Kelly Reagan, who's one of the interns who helped kind of give me the first cut of these data, and then my fellow scientists, the doctors Jewel and Raquel. Funding and conflict of interest. So this project was internally funded. So everything I'm going to show you is our own surveillance. But some of our kind of preliminary prior work was funded through the opioid analgesics REMS. And then our standard conflict of interest. We are part of the nonprofit Denver Health and Hospital Authority, which is a subdivision of the state of Colorado. But outside of this work, we're supported by pharmaceutical manufacturers, government and non-government agencies for surveillance and research services. So how do you define a falsified medication? So one definition for a falsified medication is a counterfeit, fake, or falsified medicine may be one that is harmful to your health because while being passed off as authentic, may contain the wrong ingredients, may contain too much, too little, or no active ingredient at all, or contain other harmful ingredients. And so the concept that I'm going to present on is medicines that are passed off as authentic but really aren't. There's many different forms that these falsified medications can take. Some that have been reported and researched are prescription opioids, so these are the M30s that Rick was talking about in the beginning. Amphetamines, so the Adderall and other derivatives have been falsified. Semaglutide, the GLP-1 agonist, Botox, HIV medications, alprazolam, Xanax, all of these have been reported as being produced in an inauthentic way. Based on some pilot data, our group last year estimated that 1.8% of all adults in the US in 2022 suspected they had used a falsified medication in the past year. And the data I'm showing today advances upon that initial pilot work. Initially, we reported that fentanyl was the most commonly suspected product in falsified medications, but we're finding, as you'll see, a lot more different ingredients are being reported as what's inside these inauthentic drugs. And finally, pills containing fentanyl are increasingly seized by law enforcement. Huge increases in 700-800% increase in the number of falsified pills that are containing fentanyl specifically have been increasingly seized. And so what groups may be at risk for this emerging potential public health risk from falsified medications? We added a module to our survey of non-medical use of prescription drugs program. And so this is our general population survey. It surveys 60,000 individuals a year from the general public. So we use an online panel. And so our recruitment strategy doesn't start with individuals entering any kind of healthcare services or reporting any kind of drug use. We start from the general public. And so this is what gives us the ability to estimate national patterns across the entirety of the US. We content validated some preamble text. So the concept of falsified medication is challenging to measure. So you have to first explain to an individual what it is that you want them to answer, and then ask the individual kind of behavioral questions. So the beginning part of this study was to determine some text that would prime the individual or tell them what we're going to ask them about. And so in first quarter of 2023, we did some content validation on this preamble text, which goes like this. The next few questions ask about drugs that are made to look like real FDA-approved prescription medications, but they are made illegally and not by a drug company. They may contain too much or too little drug, or they may contain the right drug, may not contain the right drug, or may contain no drugs. These are often referred to as counterfeit, falsified, fake, pressed, or laced pills. And so the public tended to use the term counterfeit, and so all of our questions included that term as part of our question series. The module that we added included several behavioral questions. And so we asked, one, were individuals seeking the counterfeit medications? And quite a number of people were seeking out the counterfeit drugs. We asked where they got them. We asked them what suspected ingredients they thought was in the medication or the falsified medication, and what authentic medication was the drug supposed to mimic. We asked them about what health events they attributed to the use, and we asked them what confirmation methods they used to determine that it was in fact a falsified drug. And currently we have some additional content validation and process that's funded to really ensure the interpretability of the entire suite of questions we're asking here for this emerging area. Because it's part of our NMURx program, it leverages all of the best practices that we've developed for NMURx over the years. We use calibration weights to ensure that our estimates are nationally representative. We use careless response exclusions to lower the number of false positives in the data. We randomize our questions so that it lowers the order effect bias in the questions so that earlier questions are not preferenced over later questions. We interleave questions, so meaning we ask questions in a series such that it lowers the number of false negatives. It reduces that motivated underreporting. If you've ever taken a survey, sometimes you'll see one question and you'll say yes, and it opens up like 5 more. If you see another question of the same type, you might be inclined to not say yes because you don't want to answer 5 more questions. And so we order the questions in such a way that we get all of their answers first before we show them the rest. So we make sure that they are not answering questions in a way that is more negative or false negatives. Adaptive questioning, so that's controlling that length of interview. And lastly, it's a large sample size, so we ensure we have statistical power to measure these small, low power or low prevalence behaviors. Finally, all these data are from first quarter of 2024, so just earlier this year. We're reporting on past year behaviors used, and I'm using the term suspected falsified medication because we want to represent these are what people think they're encountering. So it's not just a self-report, but it's a suspicion of what they think is in that falsified drug. We had a total of 1,500 individuals who reported falsified medication use, and everything I'm showing you here is statistically weighted. So let's start with who's at risk. Overall prevalence, suspected use within subgroups, and what medications they think are being falsified. So we estimate 2.7% or 7 million adults in the first quarter of 2024 suspected they used a falsified medication in the past year. Prevalence was higher in the West, 4.2% of adults in the West suspected use. And then 32% of individuals who used or suspected they used a falsified medication actually sought it out from the beginning. Suspected falsified medication use is as common as use of other illicit drugs. So estimating that 7 million using falsified medications, comparatively 4.1 million reported illicit opioid use, heroin, fentanyl, or the fentanyl analogs. 8.2 million reporting illicit stimulant use, cocaine, crack, amphetamine, and methamphetamine, and then 8.2 million illicit psychedelic use, psilocybin, LSD. In these figures, along the X, you'll see overall prevalence, and then along the Y are individual subgroups and what the prevalence of use within that subgroup is. And so you can see, somewhat unsurprisingly, that the younger adults, 18 to 35, had the highest prevalence, over 5%, almost no likelihood of someone suspecting falsified medication use in 55 plus, 35 to 55 kind of right there on the national average, which is what the dotted line represents. Higher prevalence of use in cisgender males, and then higher prevalence of use in the West, and lower prevalence of use in the Midwest relative to the national average. Mental health comorbidities, substance use, and chronic pain are all risk factors for suspecting falsified medication use. In this figure at the top, this is kind of the reference group. This is the none of these, so individuals not reporting pain, anxiety, depression, suicidal thoughts, or substance use. And you can see the prevalence of suspected use in the none group is quite low. Those reporting chronic pain in the past year, reporting about 5%, so right near that national average. And then going down from there, prevalence of use within that subgroup is much higher. So individuals reporting moderate to severe anxiety or depression, around 8%, suicidal thoughts over 10%, and individuals with a likely substance use disorder based on their DAS-10 score, over 15% likelihood of saying that they've used a suspected falsified medication. We also took those two groups of chronic pain and anxiety and depression and split out whether they are receiving care or not. My initial hypothesis was individuals who are receiving care would have a lower prevalence, and you can see that's not how it turned out. And so that top is that none group, so again, as a reference. When we look at chronic pain, individuals receiving care or seeing a doctor for their pain still sits right around 5%, the national average. Those who did not receive care have a slightly higher likelihood of encountering a falsified medication. But when it comes to anxiety and depression, it's much different. And so individuals who are receiving care had a much higher likelihood of reporting falsified medication use relative to those who didn't receive care. And that disparity, I thought, was quite striking. People suspected a large variety of drugs were being falsified. So again, I show you the question here just to give you a sense of what an individual is actually responding to. And so we asked them, in the past 12 months, when you got counterfeit drugs, what real medications did they look like? And a large variety of substances were reported. Oxycodone, which is what those M30s are, was the highest, most prevalent substance, but nearly equally were individuals thought they were receiving hydrocodone, amphetamine, alprazolam, an OTC drug, HIV medications, and 10% reported that it was something other than that group, which could really include a large variety of potential substances. Out of those who suspected they've used a falsified medication, 35% actively sought them out. And regardless of whether they sought them out, the primary source was an online source. So this is an online pharmacy, potentially the dark web, could be a general Google search. But overall, that was the predominant mode that individuals were acquiring the falsified medications, whether they sought them out or not. But those who sought them out very much preferred or reported that they used an online source. So over 75% reported an online source relative, was where they received the falsified medication. So now let's talk a little bit about the risks. Talk one about the methods of identification, suspected types of ingredients that individuals are encountering, and the consequences that they are attributing to their use. 75.1% think that the falsified medication had something other than fentanyl. So particularly when we talk about law enforcement seizures, we talk about fentanyl. Individuals are reporting that fentanyl is not the majority substance that they think is in the falsified medication. 31.6% say they've used some kind of emergency service due to the falsified medication use, and 37.8% used some kind of objective test like an at-home test or a drug checking service to identify what was in the falsified medication. So let's start there. Among adults who suspecting use, fewer than half used what I classified as an objective measure, so an at-home test or drug checking service, to identify the components of the substance that they're using. Another 24.7% used a subjective resource without using an objective test, and so this would be using something like an online reference image to look at the substance, using the texture, the feel of the pill, or it used a trusted person, someone else, to inform what was in the substance. Only 3%, thankfully, only used like how the drug felt to know that it was falsified. So this would be someone who used a substance and then it felt differently than what they were suspecting. And then 34.5% didn't report any method of knowing that it was falsified. While the highest percentage of adults suspected fentanyl, many other drugs were suspected. So individuals reported methamphetamine, heroin, ketamine, xylazine, all as potential substances that were in these falsified medications. And 14.7% reported nothing at all was in the falsified medication. So while I think fentanyl is certainly a major component, it's certainly a major component when it comes to fatal overdose. Individuals themselves are reporting that a lot more substances are in the falsified drugs that they're using. And finally, what are the health risk individuals are reporting? So a substantial proportion of adults are reporting some pretty significant health events. So 31.6% used in an emergency service. This would be something like calling 911, going to the emergency room, or calling a poison center. 27% reported contracting an illness, so this is either through a needle injection or sex. And 22.3% reported seizures, 21% panic attack or paranoia, and 17.1% reported passing out. And I think this variety of consequences can be attributed to the variety of substances that are being reported are in the drugs that they're using. So to conclude, first, the strengths of the study. So we're using all of those well-established sampling, bias mitigation, statistical methods that I talked about for NMURx. We also content validated that priming text, so I think we feel pretty good that we have a preamble text to ensure that the individual taking the survey understands the kind of behavior we're asking them about. And we are in progress for that more detailed validation of the component behaviors after that priming text. Limitations, so the first is the data are self-report, which is a standard limitation for surveys, but I think in this case it's even more relevant because what we're representing here are people, only those who suspected use, and so this excludes individuals who didn't suspect that they used a falsified medication. If they didn't know, then they couldn't report it, or survivorship bias for sure, individuals who've died because of their substance use. And we're also looking to add some more emergent medications that haven't been included before, and so these would be like the GLP-1 agonists that could be falsified. So to conclude, falsified medication use is as prevalent as other illicit drugs. There's higher prevalence in the West regions, and that's consistent with overdose data that show there are more deaths involving falsified medications in the West relative to other regions, so it's great to see our data kind of converging with that mortality data. And then chronic pain and mental health comorbidities are both markers of risk for suspected falsified medication use. There's a large variety of suspected ingredients that are being encountered, and I think we need to avoid what one author has called the tyranny of the molecule and really listen to what people are thinking. Fentanyl definitely has a major impact on people's lives, overdose, fatal, non-fatal for sure, but individuals are reporting a large variety of substances that they're encountering in a variety of potential outcomes that are they're experiencing in addition to potentially unmet medical need that may be causing their desire to use a falsified medication. And then finally, there's this exceptionally high risk of use in those with mental health comorbidities. With increasing anxiety and depression, particularly among younger adults, this may be a component driving that high falsified medication use. And personally, I'm particularly have this need to understand better why those who are receiving care for mental health are at higher risk. Is this because there's a limited access for the care that they maybe need and not receiving the care that they need? Is it these unregulated online pharmacies, of which we know there's far more than I had suspected out there, or drug shortages? What are the components that may be contributing to that high risk for these individuals? My references if anyone wants to take a gander, and I thank you for your time.